An industrial zone in liberated territory. 13-20 hours during winter afternoon. Temperature -14 Celsius with wind from west at 15 kilometers per hour. Clear conditions allowing observation and targeting. A Russian field hospital established an industrial facility seeking shelter from extreme cold and operational concealment. 520 personnel organized in field hospital operation. 380 wounded soldiers receiving treatment. 94 medical staff including surgeons, nurses, and technicians. 46 security and logistics personnel. Hospital occupied large industrial building with heating systems providing warmth in freezing conditions. Facility was positioned in industrial zone with multiple storage warehouses and chemical processing buildings nearby. Legacy Soviet-era fertilizer production complex. Medical equipment and personnel represented substantial investment. Field hospital contains surgical capabilities including 4 operating rooms, intensive care capacity for 60 patients, pharmacy with medical supplies, diagnostic equipment, communication systems. Equipment value exceeded $4.8 million. Medical staff training was extensive. Surgeons required 12 years education and training valued at approximately $400,000 each. Specialized nurses, 3 years at $90,000. Technicians, 2 years at $55,000. Combined medical staff training investment exceeded $43 million. Wounded soldiers represented $11.6 million in training investment, recovering from injuries sustained in prior operations. Adjacent to hospital, 200 meters west, stood chemical storage warehouse containing Soviet-era industrial chemicals. Facility stored agricultural chemicals, including anhydrous ammonia and chlorine compounds used in fertilizer production. Operations had ceased years ago, but storage remained undisturbed. Approximately 80 tons of anhydrous ammonia in pressurized tanks, 40 tons of chlorine in compressed cylinders. Materials were toxic. Ammonia causes severe respiratory damage and death at concentrations above 300 parts per million. Chlorine causes respiratory failure and death at concentrations above 1,000 parts per million. Ukrainian forces identified hospital location through signals intelligence and reconnaissance. Hospital was legitimate military target under international law, treating combatants and returning them to combat. Location adjacent to chemical storage created opportunity for enhanced effect attack. Artillery strike targeting chemical storage would create toxic gas release affecting hospital area. Wind direction from west would carry toxic cloud directly toward hospital. Attack would use minimal ammunition, achieving disproportionate casualties through environmental exploitation. Ukrainian investment in operation was minimal. 3 artillery rounds valued at $1,500 each, totaling $4,500. Reconnaissance and planning consumed 2 days. Analysis valued at approximately $8,000. Total operational investment approximately $12,500. 18 minutes after artillery struck chemical storage, 290 personnel would be casualties. 227 dead from acute toxic exposure to ammonia and chlorine gases. 63 critically wounded with severe respiratory damage, dying within hours. 230 survivors evacuated with varying degrees of chemical exposure, requiring extended medical treatment. Hospitals ceased operations, losing all patients and medical capability. Total losses exceeded $28 million, combining medical equipment, personnel training investment, and strategic impact of losing field hospital capability. This happened days ago during period of extreme cold forcing concentration in heated facilities. Industrial zone remains contaminated, requiring hazmat operations. Strategic implications of chemical vulnerability continue affecting facility selection. This is what occurred during those 18 minutes when wind carried death. Chemical warfare is prohibited under international conventions. However, attacking legitimate military targets adjacent to industrial chemical storage is lawful even when secondary effects include toxic release. Responsibility lies with force positioning military assets near chemical hazards. Environmental exploitation, using natural or industrial conditions to multiply attack effects, is recognized military tactic not violating chemical weapons prohibitions. Industrial chemicals can be as lethal as military chemical agents. Anhydrous ammonia is widely used in agriculture, but extremely toxic. Attacks respiratory system, causing pulmonary edema and respiratory failure. Chlorine gas was used as chemical weapon in World War I, causing thousands of casualties. Both chemicals are heavier than air, causing them to flow downhill and concentrate in low areas. Cold temperatures reduce dispersion, keeping clouds concentrated longer. Field hospitals are legitimate military targets when treating combatants who will return to combat. International humanitarian law protects civilian medical facilities, but military medical facilities supporting combat operations are targetable. Positioning medical facilities near civilian areas or chemical hazards is military decision carrying inherent risks. Russian field hospital had been operating at location for 6 days. Position was selected for multiple advantages. Large heated industrial building provided shelter from -14 Celsius conditions. Proximity to front lines reduced evacuation time for wounded. Industrial zone offered concealment from aerial observation. Security assessment examined potential threats, but didn't adequately evaluate chemical storage risk. Chemical storage warehouse was Soviet legacy from 1980s fertilizer production. Facility appeared abandoned. No activity, minimal maintenance, obvious neglect. Assessment concluded warehouse posed no threat. Error was failing to investigate warehouse contents and evaluate toxic release potential from artillery damage. At 13:20, Ukrainian artillery battery 8 kilometers away received fire mission. Target coordinates specified chemical storage warehouse, not hospital directly. 3 150mm high explosive rounds were allocated. Fire mission objective was structural destruction, causing chemical release that would drift into hospital area due to west wind. At 13:22, first round impacted warehouse roof, penetrating into storage area before detonating. High explosive detonation created overpressure rupturing ammonia storage tanks. Pressurized liquid ammonia released explosively. Pressure differential caused liquid to flash into gas, creating white vapor cloud. 80 tons of anhydrous ammonia began vaporizing at rate of approximately 2 tons per minute. Second round struck 30 seconds later, hitting different section of warehouse containing chlorine cylinders. Explosion ruptured multiple cylinders, releasing compressed chlorine gas. Yellow-green chlorine cloud mixed with white ammonia vapor, creating toxic mixture. Combined release created gas cloud visible from kilometers away. White and yellow-green vapor rising and spreading downwind. Third round was unnecessary but fired per mission parameters. Impact created additional structural damage, increasing release rate. Warehouse roof collapsed into storage area, rupturing additional containers. Gas release accelerated. Wind at 15 kilometers per hour carried toxic cloud directly toward hospital, 200 meters downwind. Cloud moved at ground level. Cold temperature and gas density caused it to hug terrain. Travel time from warehouse to hospital was approximately 1 minute. At 13:24, toxic cloud reached hospital perimeter. Security personnel outside noticed visible vapor approaching. Alert was given, but insufficient time existed for effective response. Cloud engulfed building within 30 seconds. Vapor entered through ventilation system, door openings, and structural gaps. Building was not sealed for chemical attack. Ventilation actively drew outside air inside for heating system operation. Initial exposure symptoms appeared within seconds. Personnel near entry points experienced immediate eye irritation, throat burning, difficulty breathing. Those in areas where gas concentrated experienced more severe symptoms, violent coughing, chest pain, inability to breathe. Ammonia attacked mucous membranes in eyes, nose, throat, and lungs. Chlorine caused similar respiratory effects with additional pulmonary edema. Fluid accumulation in lungs preventing oxygen absorption. Medical staff recognized chemical exposure immediately. Emergency response protocols were initiated. Close all openings, activate chemical alarms, issue protective masks. However, hospital lacked adequate chemical protective equipment. Only 40 gas masks were available for 520 personnel. Wounded patients were immobile and couldn't evacuate. Medical staff had to choose between saving themselves or attempting to protect patients. Most medical staff remained attempting to protect patients despite lacking protection. Surgeons in operating rooms continued surgeries while exposed to toxic vapors. Nurses moved patients toward areas with better ventilation. Technicians attempted closing doors and sealing rooms. Actions were heroic but insufficient against gas concentration. Wounded patients were most vulnerable. Many had respiratory injuries from previous combat requiring supplemental oxygen. Chemical exposure destroyed remaining respiratory function. Patients on ventilators died as lungs filled with fluid, preventing gas exchange. Those breathing independently lost ability rapidly, as airways swelled and filled with secretions. Death occurred within 5 to 15 minutes for most patients. Medical staff exposure caused casualties among most skilled personnel. Surgeons and nurses working in patient areas received highest exposures. Some died at their stations. Surgeons found dead in operating rooms. Nurses collapsed beside patients they were protecting. Others evacuated but suffered severe respiratory damage, causing death within hours. Gas concentration inside building peaked at approximately 1327, 5 minutes after initial exposure. Ventilation system distributed gas throughout building, ensuring comprehensive exposure. Some areas had higher concentrations based on airflow patterns. Intensive care unit had highest casualties. 60 ventilated patients all died from respiratory failure. 8 medical staff died attempting to save them. At 1329, security personnel outside organized evacuation attempt. Doors were opened and personnel began exiting. Evacuees emerged coughing violently, eyes streaming, gasping for air. Many collapsed immediately after reaching outside. Chemical exposure combined with -14 Celsius temperature created additional shock. Respiratory distress in extreme cold accelerated hypothermia. Evacuation was chaotic and incomplete. Mobile personnel evacuated first. Medical staff and security personnel who could walk. Wounded patients couldn't evacuate independently. 380 patients required assistance, but only 76 ambulatory personnel remained capable of helping. Triage decisions were brutal. Save those who could walk, abandon those who couldn't. Many were left inside dying from exposure. Some medical staff refused to abandon patients. 18 personnel remained inside attempting to evacuate non-ambulatory patients. They moved patients toward exits using stretchers and manual carries. Most collapsed from exposure before reaching outside. Heroic actions saved approximately 30 patients but cost lives of rescuers. Gas cloud persisted over hospital area for 12 minutes before wind dispersed it sufficiently for safe approach. During this period, personnel outside couldn't re-enter to rescue those trapped inside. Sound of coughing and gasping came from building, but nothing could be done. Rescue teams assembled but lacked chemical protective equipment for entry. At 1334, gas concentration decreased, allowing rescue entry using improvised protection. Wet cloth over faces providing minimal filtering. Teams entered finding devastation. Bodies throughout building, survivors barely breathing, equipment abandoned. Rescue operations extracted survivors, but many died during evacuation or shortly after from exposure effects. Casualty assessment revealed catastrophic losses. 227 confirmed dead from acute chemical exposure. Died within 18 minutes of initial exposure. Bodies showed characteristic chemical injuries. Pulmonary edema causing pink frothy fluid in airways. Chemical burns in respiratory tract. Corneal damage from ammonia exposure. Most deaths occurred in first 10 minutes, indicating high gas concentration. 63 critically wounded died within 24 hours despite medical treatment. Chemical exposure caused acute respiratory distress syndrome. Lungs filled with fluid preventing oxygen absorption. Mechanical ventilation was insufficient. Damaged lung tissue couldn't support gas exchange. Some patients developed secondary pneumonia in damaged airways. Others had multi-organ failure from prolonged hypoxia. Medical treatment options were extremely limited for chemical exposure casualties. 230 survivors required extended medical treatment. Injuries range from mild respiratory irritation to severe chemical burns requiring grafting. Many had permanent respiratory damage, reducing lung capacity and requiring lifetime care. Some had vision damage from corneal chemical burns requiring corneal transplants. Medical costs for survivors exceeded $3.2 million for initial treatment, with ongoing costs for chronic care. Hospital equipment was abandoned during evacuation. $4.8 million in medical equipment was left inside building. Chemical contamination made equipment unrecoverable. Decontamination cost exceeded replacement value. Surgical equipment, monitors, ventilators, diagnostic machines, pharmacy supplies, all were total losses. Hospital capability was completely destroyed. Personnel losses exceeded equipment value enormously. Medical staff casualties represented catastrophic loss. $43 million in training investment for specialized surgeons, nurses, and technicians. Replacing medical personnel required years. Training new surgeons required 12 years. Nurses 3 years. Immediate medical capability gap was unfillable. Adjacent units had to absorb casualties intended for destroyed hospital, creating overload and reduced care quality. Wounded soldier casualties compounded losses. 380 patients represented $11.6 million in training investment, recovering from injuries. Most were expected to return to duty after treatment. Losing them permanently was equivalent to fresh combat casualties. Units that had those soldiers wounded now had them killed. Double loss. Total financial impact exceeded $28 million. Medical equipment losses of $4.8 million. Medical staff training investment of $43 million, partially lost with casualties of 94 staff. Wounded soldier training investment of $11.6 million, lost with patient deaths. Medical costs for survivors of $3.2 million. Strategic impact of losing hospital capability was uncalculable but significant. Operational impact was immediate and severe. Field Hospital provided surgical capability for 3 frontline divisions. Destruction forced medical evacuation to hospitals 100 kilometers rear. Additional transport time cost lives from delayed treatment. Some wounded died during extended evacuation who would have survived with immediate hospital care. Medical support degradation reduced units' willingness to conduct aggressive operations, knowing delayed treatment meant lower survival rates. Psychological impact affected medical personnel throughout region. Staff at other hospitals feared similar attacks. Some facilities were relocated away from industrial areas, consuming time and resources. Medical personnel became reluctant to serve in forward facilities, creating staffing problems. Overall medical capability decreased approximately 15% from combination of destroyed facility and reduced efficiency at remaining facilities. Strategic implications affected facility selection throughout operational area. Industrial zones were recognized as high risk due to legacy chemical storage. Facility surveys for chemical hazards became mandatory, consuming engineering resources. Some otherwise suitable locations were rejected, creating facility shortages. Medical capability positioning became constrained by chemical safety, reducing operational flexibility. Comparative analysis showed Ukrainian investment of $12,500 destroyed medical facility worth $28 million immediate losses, plus uncalculable strategic impact. Return ratio exceeded 2,200 to 1. Every dollar invested eliminated over $2,000 enemy medical capability. Operation demonstrated extreme effectiveness of environmental exploitation. International law analysis confirmed legality. Chemical storage existed prior to hospital establishment. Hospital positioning near chemicals was Russian decision. Artillery targeted warehouse, not hospital. Hospital casualties were consequence of Russian facility placement. No chemical weapons were used. Conventional artillery caused release of industrial chemicals. Responsibility for casualties lay with force positioning military medical facility adjacent to toxic chemical storage. The afternoon was clear and cold. The wind was steady from west. 3 artillery rounds struck warehouse. 80 tons of ammonia and 40 tons of chlorine released. Wind carried toxic cloud 200 meters to hospital. 18 minutes from impact to mass casualties. 290 dead or dying. Hospital destroyed. $28 million lost. All from environmental exploitation, using industrial chemicals and wind direction to multiply 3 artillery rounds into catastrophic attack. Medical facilities require safe locations. Positioning near chemical hazards creates vulnerability. Artillery needs only breach containers. Wind and chemistry do the killing. No chemical weapons necessary when industrial storage provides toxic agents. 3 rounds created effect exceeding conventional bombardment by orders of magnitude. Wind direction determined casualties. Temperature and terrain kept gas concentrated. Result was field hospital destruction through environmental weapon created by Russian facility placement decisions.